Hello, everyone. This is Carly Beam with Becker's Healthcare, and thank you so much for joining us for today's webinar, The $15 Million Problem Hidden in Your Charts, How AI Closes Care Gaps Before They Cost You. Before we begin, I'll walk us through a few quick housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a Q&A session. You can submit any questions you have throughout the webinar by typing them into the Q&A box on your screen. Our session is also being recorded, and it will be available after the event. You can use the same link you used to log into today's webinar to access it. And if at any time you have issues with audio or visuals, just try to refresh your browser. You can also submit any technical questions into the Q&A box, and we'll have someone help you out. And with that, I'm pleased to introduce today's speakers. Dr. Jason Cohen is Chief Medical Officer of Inpatient at Qventus. In this role, he is responsible for the design and direction of the Qventus inpatient solution, which reduces length of stay and creates capacity by automating key components of highly effective discharge planning. Dr. Cohen is also a practicing hospitalist, and before joining Qventus, he was Chief Medical Officer at North Valley Hospital. Dr. Cohen received his Doctor of Medicine degree from the University of Chicago, and he has a bachelor's degree in political science and government from Wesleyan University. And Katie Sandin is Senior Director of Product Management at Qventus, where she worked for 5 years. There, she's focused on building AI solutions that automate hospital operations for the benefit of patients and clinicians. Before joining Qventus, she spent 6 years at GE Healthcare. Thank you, Dr. Cohen and Katie, for being here today. And I'll turn the floor over to you to get us started.
Awesome. Thanks so much. Appreciate everyone being here today. I'm not quite sure how my degree in comparative politics is going to come in handy today, but we'll just have to see how things go. So the agenda for today, we're going to talk a little bit about why this is a problem today, like why complex conditions go undetected, what the cost is associated with that. Also talk a bit about why closed-loop orchestrations are so critical today, particularly with how busy care teams are and how many things we have to worry about in our daily lives. We'll, of course, cover the Qventus Care Gap Encoding Automation Suite. Katie will do a demo of that, and we'll go through some outcomes with some recent customers. So without further ado, next slide here, just to kind of let you know who Qventus is, for those of you who may not be familiar with us. We've been helping health systems automate healthcare for over a decade. Many of you may be familiar with our other solutions on our platform, including our inpatient capacity solution that's all about helping hospitals build good patient throughput to increase capacity and serve their mission to their community. We also have a surgical growth solution that's all about helping you make better use of your white space and fill that white space with strategically important surgical cases, increase use of your robots, and grow strategic volumes. One of our more recent solutions, our PAT solution, all about helping you use your labor more efficiently in those high labor areas of operations, including pre-anesthesia testing, helping you decrease your case cancellations and improve outcomes for surgical patients. All of those drive really significant ROI, 10x ROI. Most of our customers see a 2-month break even across all of those solutions. And probably the part I'm proudest about in terms of working at Qventus and being a part of this organization is our class rating. 100% of our clients report that Qventus is part of their long-term plans. Lots of reasons for that. I'm sure our AI and advanced solutions are a core part of that, but I think the other piece that often gets missed, particularly for those of us who are on the receiving end of technology and solutions and so forth, is just how important it is to find a partner who truly partners with you, who truly spends the time to understand the problems you have and the challenges your care teams face, and can build and integrate solutions into existing workflows and in a way that truly supports those care teams and solves a strategic problem. That's a different kind of partnership. And that's why, all the different health systems you see here, large, small health systems, academic, non-academic, see us as part of their long-term plans. And we're very fortunate and grateful to work with them. So the topic of the conversation today is of course the care gaps and coding gaps that we see in inpatient operations. Huge cost associated with that. Of course, there's the direct costs from missing those conditions and when they go uncoded, whether that's an MCC code or a CC code. But it goes beyond the financial piece, and it certainly impacts patients. So in the case of malnutrition or acute kidney injury, acute renal failure, whatever diagnosis area you're talking about, patients that have those issues unaddressed, unrecognized, see greater risk of readmission, as well as a longer length of stay. That also impacts your hospital when it comes to quality metrics, right? So if you're not picking up those codes, you're not capturing the clinical complexity of the patient population you serve, your O to E ratios are going to suffer as a result. So main idea here, yes, this is a financial problem, but also very much one that impacts our patients as well as our performance. So why do we still have this problem today? Like, we all know that, I think all of us who are clinicians, or whether you're a CDI specialist or you're in the CFO or C-suite, like, we've been working on CDI for years, like, but it continues to be an issue for all of us. The reason for that is that a lot of the solutions today really aren't built with an end-to-end orchestration kind of framework or mindset. You know, it's clinicians getting an in-basket message after a patient has already discharged, asking for clarification on a condition that really the cow's already out of the barn. That the patient on your opportunity to intervene on that patient has been missed. A lot of the data that we may try to build some models into our own EHRs if we have that sophistication, but generally you don't have access to the unstructured data. You might be able to pull in a weight or a creatinine or something like that, but being able to actually take advantage of provider notes, case management notes, physical therapy notes, it's largely missing from a lot of that logic. And because of all those gaps, there's just a lot of leakage in terms of both identifying the problem as well as making sure that those patients get the right care and that you're coding it appropriately. To really solve this problem, you need that end-to-end orchestration. Patients are clearly at risk of having these diagnoses missed. Really important to identify those patients as early as possible and stay if you're going to intervene. You have to make that visible to care teams, and it can't just be another alert or an email or a dashboard they have to go to. You really have to embed that in their existing workflow, whether that's in a patient list, in a side panel, in a print group, in a banner. You have to put it where people are already working so that they can see it, take advantage of it, and it doesn't slow them down. The other important piece here is it can't just be an alert. You need to always be biasing towards action. You need to be helping the care team take the right next step, whether that's an order for a nutrition consult or prompting a nurse to follow a protocol to remove a Foley catheter, whatever the case may be. Really important that you're biasing towards action for busy care teams. On the back end of that, you need to make sure the documentation is correct. So you may have clinicians that are good at capturing some of these conditions, but they're not so great at getting the right documentation in place. You're already doing all the work. The patients are getting the right care, but because of the lack of appropriate documentation, you're not actually able to capture that MCC or CC code. And then the last piece is, of course, just making sure you're getting adequately reimbursed for that care you're delivering. Like, all of these pieces have to be in place for you to have a smooth functioning end-to-end orchestration that's capturing that clinical complexity and making sure that your health system is adequately getting reimbursed, those patients are getting the right care, et cetera. So with that introduction, and I'm going to hand it off to Katie here in a second so that she can actually show you more up close what that looks like for malnutrition. I'm interested in your all's experience today, like thinking about that end-to-end process that needs to be in place. What are the biggest barriers that your organization faces in closing those care gaps and those coding gaps? And you've got four opportunities here. I suspect the answer is all of these, but what is the one that stands out most to you? I see 0 submitted. Is there anything I need to do, Becker's folks, to kick this off? To launch? Oh, I got 1. Okay.
Numbers are climbing. We're on the board.
I still have 1. 10. Wonderful. Okay. 25? We could start a small betting pool on what the final number will be, but I suppose I have some. Got over a third of attendees. That feels like it's getting pretty close to a statistically significant number. I'll give anyone a final chance here to weigh in, and then the big reveal. So physician documentation that accurately reflects clinical complexity clearly coming in first, and then the other three kind of in a three-way tie. Yeah, that's my experience too. I think I'm curious. I don't know if anyone wants to put some thoughts in the Q&A, but I think lots of different reasons for that. I think as physicians, we want to document appropriately. Part of it is that we're just not trained to it, right? During residency, this isn't something we learn. A lot of it, I think, also comes down to like that time element where, we get a lot of these prompts or find out about this stuff either late in stay or after the patient is discharged, and really just hard to get busy clinicians, particularly maybe those hospitalists that are working week on, week off, to double back and actually improve the documentation so you can capture that. Thanks for all of that. Anything in the chat there that's...
Yeah, I was going to jump in. I see Ken called out, that working on a malnutrition program, having trouble getting physicians to agree with dietitians on the coding. I think that's one of the benefits that we've seen in rolling out the program that we have, which I know I'll get into in a minute, on how do we ensure that we're servicing the same information to physicians and dietitians alike so that everyone is operating from the same context of information on what's being seen in the chart. And then the other thing that I'll talk about more is aligning on what criteria framework is being used. So whether it's Aspen, GLIM, some sort of combo can also help align folks on how we're assessing this patient's risk of being malnourished to help move folks forward. So you're not alone, Ken, and we've seen that at other places and have helped with some of that with the solution. The other thing I was just going to say based off of the poll is, because I look at a lot of data, we had one organization in particular, just to put a number to what you're describing, that we saw about 50%, it was I think like 47% of the time that a dietitian was diagnosing the patient as malnourished, the physician's documentation didn't reflect that, and that patient didn't get a code. And that is, as we talk about the title of this webinar, that is dollars on the table that patient has been diagnosed, and we're just missing some of those final steps to secure that. So completely agree that is one of the top problems and something that we've been, of course, thinking a lot about.
Awesome.
And with that, let's talk about
Perfect.
So we're going to talk about how we've been solving this end to end. As Jason mentioned, it really does take an end-to-end solution to solve this well. If you want to go to the next slide, or if I can do that, I think actually, cool. So we are approaching this really as a holistic suite. So one of the things that you also heard Jason talk about is that, hey, while there are point solutions on the market, when we think about all of the different conditions that fall under this realm of having both a care and a documentation gap, wanting to make sure that if we're going to reach out to physicians, reach out to the nutritionists, case managers, whoever needs to interact with these, that it's being done in a consistent way so that we're not bombarding folks with different tools and different methodologies to solve some of these specific condition pain points. So our solution really has four main skills, moving from detecting the condition itself, surfacing the information to the right individual at the right time to take the right action from a care detection perspective, and then making sure that the physician's documentation reflects the care that was given. And finally, in our impact assistant, giving you all as leaders visibility into how teams are engaging with the solution, what the increase in code capture has been, mortality O to E, length of stay O to E, how we've improved those, all of that information at your fingertips so that you have that information to continue improving and moving forward. You can see some of the solutions that we've been applying at the top. Malnutrition is our first, but we're actively starting to focus on pressure injuries, AKI, as well as delirium and encephalopathy as some of the next conditions, with many more to follow. But they all follow that same pattern of having both a care element that needs to be in place in order to get that reimbursement, and then obviously the documentation has to reflect that as well. So we're going to a poll again. I would love to hear from everyone. And if you can help me advance, Jason, or our Becker's friends. But what the poll is going to be is I want to hear from you on some of the top conditions on your mind as to what is most needing a solution like this, or where you see the biggest gaps.
Are you able to see the poll, Katie? Yeah, I see someone who's submitted,
Yep.
so clearly.
There it is.
Great.
Yep.
Just while people are responding, like Ken mentioned that it's they validated that the opportunity is worth $2 million to them. Not a huge surprise to hear that. I think we'll actually share some outcomes later that are around that same magnitude. What's incredible to me as a CMO is that like we're already providing most of this care for these patients. Sometimes there's a gap. There's patients we don't recognize, and actually Katie's on site somewhere and at a customer today and has heard some of those stories. But a lot of the time, these are patients we're actually being seen by dietitians. We're intervening. We're doing stuff to help improve their outcome, but we don't capture their clinical complexity. And it is literally like money on the table that we could be using to serve our mission for other patient populations. It looks like we have about 36%. We'll see if anyone else wants to throw in an answer here. So what conditions represent the greatest untapped opportunity? Severe malnutrition, AKI, encephalopathy, acute respiratory failure, or sepsis? I'm gonna make a guess here that A gets the most, E gets the second. I'm gonna go like 40, 25, and then like 15 for each of the others. Oh, wow, it was even more. Oh, people must be able to pick more than one answer, because I think that adds up to more than 100%. That adds up to like 150%.
Top two,
yeah,
yes.
Yeah, so sepsis and malnutrition.
Awesome. And that's consistent with what we hear from other folks that we've been chatting with, and really what the data shows as well, when you look at some of the Vizient reports and whatnot on where folks have the biggest opportunity in this space. If we want to go to the next slide, we are going to talk more about that top condition that has been flagged, which is malnutrition, right? So malnutrition, again, I'm sure I'm preaching to the choir, but what research shows is that anywhere from 20 to 30% of inpatients are malnourished. Yet, it's a highly undetected condition. So as I've looked at various organizations we've been partnering with, I see anywhere from 5 up to 15, 16% of patients getting captured, with the average being more around 10%. So clear opportunity to get to that, what research shows is more like 20 to 30%. When those patients go undetected, we know that these patients are more than 2 times likely to readmit to the hospital. These patients typically have a longer length of stay. Of course, it impacts all those quality factors, and then dollars on the table, right? So we estimate, and Ken, I think you right on the money there with 2 million there, anywhere from 3 to 5 million is what we see as the missed revenue annually, depending on your discharge volume. So as far as what our solution looks like at a high level, and then I will go into a demo, I mentioned on an earlier slide that we have 4 main assistants. So our condition detection assistant, just adding a bit more color, we look at both structured and unstructured data in real time. So our models run every single day on all inpatient adults to detect some of these changes. We're looking at, as Jason mentioned, physician progress notes. We're looking at nursing notes for any change in intake over the next couple of days. We're looking at physical therapy notes on if there's been a functional decline. In physician progress notes, we're looking at things like thenar wasting, temporal wasting, cachexia, failure to thrive, right? All of those key indicators that can sometimes go missed or are just buried deep in charts, where what we see is dietitians are trying to hunt for that today to pick up those patients. But we know patients slip through the cracks. Our models detect that, and then the care gap assistant comes in, and we have 2 main ways of surfacing this information to providers. Really, to Jason's point, we pride ourselves on finding the best way to integrate in your EHRs to make it as seamless to interact with the intelligence as possible. So we, for physicians, will surface prompts to highlight that a patient may be malnourished directly in the patient's chart, and then prompt them to create a nutrition consult order, which, if accepted, we would pre-populate that order where all the physician has to do is sign it. So trying to make it as easy as possible, knowing that alert fatigue is real, and we want to make sure that it's seamless. On the dietitian side, then, we surface that information directly in their work list. So you can see, has Qventus flagged this patient as high risk, moderate risk, and why? So they have that context as they go to do a physical exam. Our coding and documentation assistant really is all, as we talked about, is ensuring appropriate capture of that clinical complexity. I saw in the chat, Elaine, you mentioned how your health system is approaching this today. We are doing something similar, but I'll tell you the twist of how we've approached it when we get into the demo. And then our impact assistant, like I said, all about giving you the insights that you need to best move this work forward. The one other piece I'll call out here is we are actively working with some partner organizations to automate the ECQM malnutrition care score reporting. If you're not aware, malnutrition care score is looking to become a mandatory ECQM in 2028. So something that we're actively working on, given that we are sitting on all of the data that is needed to report out on that ECQM. So some good stuff there as well to help folks hit 100% on their malnutrition care score screening. So that's the solution at a high level. Let me go into the demo itself. I'm going to share my screen and let me know, Jason and team, when it is up. Okay. Can everyone see this okay?
I can see it in the top right corner. I don't see it in the main screen, but I don't know what it looks like for other folks. Becker's folks, can everyone see that? Or do you have to?
I will try one more thing, and then I'm going to go, and hopefully you can see it as big as you need.
We may have to have someone stop sharing the main one. Maybe we have to stop sharing. I'm not sure. Oh, it said Summer said we can see it. So
okay, great. We'll do the same thing again then. Okay.
Thanks,
so
Summer.
What I'm going to show, thanks, Summer. This is meant to look like a generic EHR. So it's meant to look a little bit like Cerner, a little bit like Epic. We do integrate with all of the main EHRs on the market. But what I'm going to walk through is some of the main ways, as I mentioned, that we're able to surface this information to your care team members to interact with. So pretend that I am the physician in this case and the attending. I'm going through my patient list and I need to dive into Allison. I'm getting ready to see her and I want to check out what's going on in her chart. As I mentioned, our models are running every single day. So in this situation, if Qventus had flagged Allison, which we did, as being a potentially malnourished patient, we would surface that information to the provider, prompting them to create that nutrition consult order. In this example, we'd give 2 pretty basic BMI weight loss. Our models are, as I mentioned, also looking at all of the other Aspen and GLIM criteria, whether it is fluid retention, subcutaneous fat loss, anything like that. All of that could also appear in this same prompt if that had fired as true for that patient. But if in this situation, the physician is like, yep, this patient definitely needs to be seen by the dietitians, if he or she clicked to order that consult, what Qventus would do is pre-populate that order. So all the physician has to do is sign it, making it as easy and seamless as possible for them to interact with and move on in their day. So fast forward then to this consult order has been created. I'm now the dietitian working in my work list. And what we have done is we've added a column directly in their list to highlight the patients that are at high or moderate risk of being malnourished. There's a lot of flexibility in how we surface this information. In the purpose of this demo, we've chosen to show that with different icons, but we can also use text. We can have multiple columns. There's a lot of flexibility based on what's going to work best for each organization's dietitian team. In this example, we've added the hovers, so that same clinical evidence that was surfaced to the provider would also be surfaced to the physicians, so they have that context as they go to assess the patient. Not shown in this demo, but we do also give visibility as you click into each patient's chart into the specifics behind why we flagged the clinical evidence that we did. So we would give the specific quotes, the author, the note, date, time, so that everyone has that transparency and that full picture on what was behind the model predictions. So they're not having to guess or try to hunt in the chart to figure out what was behind that intelligence. So at this point, the physician has seen the information, the dietitians have seen the information. The last piece of the puzzle is, of course, ensuring that the physician's documentation ends up mirroring what the dietitian's diagnosed. Elaine, to what you called out earlier, what we're doing here is we are automating the entry of both the diagnosis and the dietitian's care plan in the physician's progress note. But what we do, part of the twist, is our models actually read all of the physician documentation to see where malnutrition has or hasn't already been called out. So we're not just automatically adding it if the documentation is already there. And at the same time, we're also checking to make sure that the specificity is there. So oftentimes what I see is that in physician progress notes, it'll call out malnutrition, but the dietitian may have diagnosed them as severely malnourished. So in that situation, you're either going to get a CDI query to rectify that, or the patient's likely going to be coded as that unspecified malnutrition, which would be the CC as opposed to the MCC. So what our models do is by reading through the physician documentation, we can help write that, surface that to the physician so they can make that correction and ultimately ensure that it gets coded appropriately to mirror and, again, align with what the dietitians have diagnosed. So that is end-to-end how we surface this information to physicians, to dietitians, and then make sure the whole closed loop system is in place. There is optionality. So in some organizations, we are going directly to the dietitians first without doing that initial prompt, because that piece is, I think, really works well in organizations where the dietitians are very consult-based. So they're not screening for patients every day. But in situations where the dietitians are actively going through every patient on their list to find some of these evidences, we find it easier to skip the initial prompt and go right to them. But there's a lot of options, I guess, is my main message in terms of how we best configure this for your teams.
And kind of to that point, Katie, Amy Mosley just asked, how does this work with nutrition screening on admission completed by nursing, like the MST? I gave an answer, but I suspect you probably have a more complete one.
Yeah, no, love the question. So the same information that's captured in the MST, we can read those notes as well and include it. What I find, though, in talking to dietitians and seeing that data is the MST does have a fair amount of false positives, right? In the sense that it's dependent on patient self-report. Oftentimes I'll see scores of 2, which usually results in that automatic consult for dietitians if a patient is unsure, right? Those standard questions, have you lost weight unintentionally in the last couple of months? Has your appetite decreased? If the patient says, I don't know, that is automatically going to flag that patient. So I think what we see working really well is taking the MST, because it is valuable information from the patient, but using it in conjunction with these models to have a higher true positive rate and reduce those false positives. So we're not bombarding the dietitians with patients that they wouldn't necessarily benefit from their services at that time. And then if anything changes, because we are running models every day, whereas the MST is just done upon admission, we can flag patients that maybe when they first entered, they were doing okay, but it's now been 7 or 8 days and things have changed and we might need to see them later on in stay.
And you told me a story, Kate, I'm going to remind you told me a story from where you are today about a patient that actually I think scored a 0. So both false positives and false negatives for MST. There was a patient who told me about.
I did, yeah. So as Jason said, I'm actively on site today with a partner. We went live with this solution yesterday. And I had 2 examples that I think are worth sharing. One had a patient that scored a 0 on the MST, and the dietitian had no idea why as we dug in. The nutrition Braden score was a 3. So normally in her screening process, that patient would not have been seen. Because our models surfaced that to the dietitian, she dug in a little bit deeper and she's like, the Braden score should have been a 2. I don't know why the MST is 0. There's clear evidence of significant weight loss, clear evidence of, we saw some fluid retention in the chart as well. And then I actually got to go and observe that dietitian do the physical exam, and that patient was diagnosed with severe malnutrition. That patient was also, it was their, they were nearing discharge. And so she told me, this dietitian, she's like, if I had not gotten this prompt, this patient would not have been diagnosed and they would have left the hospital with nothing. The other example worth highlighting is an instance where the it was separate from the MST, but I think still worth flagging that a patient was screened for a length of stay greater than 7 flag, which is pretty standard, what I see as a screening criteria amongst our partner organizations. The dietitian didn't see anything worth noting. I think in that situation, the MST was a 1 and the nutrition Braden score was a 3. So didn't do anything. And then because our model flagged that patient, it was day 11 at this point. Dietitian looked, said, normally I wouldn't have done anything because they were screened a couple of days ago with no other risk indicators. But I got to go shadow that dietitian, did the physical exam, and diagnosed with moderate malnutrition, right? So was able to see some of the loss of fat and the muscle that will happen that you can really only see with a physical exam. But again, upon that deeper check, was like, oh yes, this was a good catch. So these are just a couple examples literally from yesterday of how some of these traditional tools, while they're great and they have their merits, they also have their points where things can fall through the cracks. And so I think this is where AI and being able to automatically review all this documentation in bulk and make sure nothing gets missed can go a long way to helping solve this problem. Any other questions, comments on that, or anything, Jason, you'd add on this demo?
No, well, yes, I'll always add something. I would just say like asking people today, my own experience as a former chief medical officer, asking teams today to go do something extra, whether it's go, logging in somewhere else, reading an email, looking at a dashboard, like it's really a non-starter. Like certainly since the pandemic, it's just everyone is so busy. Like for AI to be successful today, it has to meet a couple requirements. It needs to we need to make sure we're giving teams the actual tools that solve the problem. Like, in this case for malnutrition, making sure it's linked to evidence-based criteria like ASPEN and GLIM. We have to make sure it's, and also we have to make sure it's embedded in an existing workflow. So in this case, whether it's the nutritionist or the physician, like biasing towards action, making it easy to do. So this actually isn't an extra thing. It's not like a coding, it's not a documentation thing I have to respond to after the patient's already been discharged. That it just becomes part of our daily work and that we reduce the distance between that insight and action as much as possible so that patients get the right care at the right time. And Katie, I've got the other, I don't know if you want to stop sharing. I've got the ASPEN and GLIM criteria off if you want to cover this or move me along.
Yep, no, this is perfect. Because I think to your point, Jason, I think it's important what I found that we align with the best practices and the guidelines that are already being used by the dietitian teams, right? So we do align with ASPEN and GLIM. This is configurable. So if your organization uses ASPEN, GLIM, if you want to use both, I've had organizations where their dietitians score against ASPEN, but they have payers that use GLIM. And so our models can flag whether patients meet one or the other or both, which can help everyone as they go to get ready to submit that patient for that code to make sure that the documentation is up to snuff to clear that review amongst the payer. So that's one thing I want to touch on. The other, as I mentioned, we look at a lot of data, both structured and unstructured. You can see all of the different fine print of what we're looking for, but it's those same criteria factors that is a part of both of those standard frameworks on the teams use today. The other thing probably worth mentioning is we do have some more logic a part of this where if a patient is already being seen by the dietitians, either there's a consult order already in place or the dietitians have already written a note for that patient, we exclude those. So you're only getting prompted on patients that have yet to be seen. We run the model on everyone, but again, we're trying to surface this in a way that is not noise and it's adding to your workflow versus creating any sort of duplication of what you already may be doing for that patient. So what does that look like in terms of outcomes and in what are we seeing across systems? Of course, this, as we've talked about, has an impact on reimbursement. So given, there is a difference, of course, in reimbursement if it's coded as an MCC, so severe malnutrition versus moderate or unspecified would be the CC. But if you look at those standard rates across, it's about $8,000 that you will increase the reimbursement by adding malnutrition. And that does vary. For surgical patients, I've seen as high as a $30,000 increase in the reimbursement by adding malnutrition as that code. Research shows, right, that there is a clear correlation to reduced length of stay up to 1 day shorter if those patients get identified and then treated early in stay. Productivity, that's huge too, right? A big part of what we're doing is automating the screening process that dietitians spend today. What I've seen, what I hear is that they spend anywhere from 30 to 60 minutes manually reviewing charts, reading the latest progress notes, looking through all the weight history, checking in care everywhere because the patient, their last visits weren't at the health system that we're at now. All of that takes time. And when streamlined, as you can see, has a significant impact on their time, which then gets redirected towards patient care. Mortality, right? So for both mortality O to E and length of stay O to E, by adding this code to that patient, it increases, of course, the risk or the severity of illness, which has a big impact. For more malnutrition specifically, on average, adding that code increases the risk of mortality by 7.7%. So that's a huge impact. And what we've seen at our partner organizations is, in light of that, we've been able to reduce or improve, I should say, mortality O to E by 2 to 3%. And there's a whole other slew of value-based care metrics, things like readmissions that we track as well. A little bit harder to directly correlate to the solution because there's a lot of factors at play, but we do see those benefits there as well. All that combined is about $40 per discharge. So you can imagine if you are a 500-bed health system, what that would equate to in your organization, right? It's about $1.3, $1.4 million annualized. And again, that'll vary. I know, Ken, you had mentioned 2 million. That number totally tracks from what I've seen. At larger organizations, we see that number, of course, even higher. Jason, anything you'd add here?
Sorry, I was busy answering a question from Emily on the side. I don't think so. I think it's just, again, like the focus tends to be on the reimbursement, always, but the decreased burden on the dietitians and the quality improvements. I spent a lot of my career in quality, and like anything we can do, we put an enormous effort into improving quality of care so we can get our ODE measures down. A lot of the times there's equal benefit to be had by making sure we're just adequately capturing the clinical complexity of our patients and what expected mortality would be. So just a lot of value in those other places as well. I was going to say, Katie, if you don't mind answering I'm answering Emily's question, but Amy mostly had a question. How has this affected workload? Has this justified additional FTEs? And it sounded like you were starting to get at that, but I thought it was worth addressing.
Yeah, it's a great question, Amy, because I'm actively in some conversations with organizations based on the results that they've seen on making that case for more FTEs that, hey, we have some, we also measure how long it takes for dietitians to complete the assessment. So we can see, hey, this patient was diagnosed. It took 3 days, it took 4 days. In some situations, those patients might discharge, and that does strengthen the case for more dietitians to help meet that demand. So short answer, yes, this data is helping our dietitian leaders have those conversations. What's next? So as I mentioned, malnutrition is really just scratching the surface on this care gap and coding orchestration suite that we are actively building. Where we're heading next is these 3 that you see on the screen: pressure injuries, delirium, and the encephalopathy, and then AKI with ATN. You can see all of this has a significant impact on the bottom line. But there also is, of course, differences in how prevalent that is, how often it goes undetected, but big opportunities across the board. This is, again, just the next couple that we're going to tackle. You can see at the very bottom that we also are looking at sepsis, respiratory failure, acute blood loss, anemia, and many other conditions where there is, again, that care gap element where there's either patients going missed or just inconsistencies in how care is administered. That's another thing that I hear from physician leaders that I talk to, particularly in academic medical centers where they've got new residents, fellows coming in that we just want to drive some more standard of care. This is another area where we can help streamline that. And then, of course, the documentation piece as well, to Jason's point. And my husband's actually a physician. He's like, I didn't go to school to learn how to document for coding purposes. So that's another place where we can just make that even easier for everyone. going to turn over to Jason again to talk about.
Katie's husband's a cardiologist, so he definitely didn't go to school to learn how to code any of this, this stuff. No. As a hospitalist, maybe I did, but definitely not a cardiologist.
Nope. He did his 3 years and then he kept going.
Yeah. So outcomes, right? And of course, I'm trying to, Mr. York, what's Ken's point earlier in the questions about what the economic opportunity is here. This is just one of our recent deployments across a large Midwestern AMC. And the reason I picked this one to share with you all today is because this was a system that actually scared me a little bit. They were actually doing really well identifying patients with malnutrition before we went live. This is a system that actually has our inpatient capacity solution, which is a lot of the same data that feeds the care gap encoding orchestration. And so it was very easy for us just to turn this on for them, essentially. But if you look at their pre-go live numbers down at the bottom, they were already capturing 15, 17, 18, whatever % of patients with malnutrition. So my fear was that, like, okay, they're already getting the easy ones. Are we really going to be able to help them by turning this on? So I think it was a good test of the solution. And you see the post-go live numbers. So even in places where they were identifying 18.3% of patients, we were able to increase that by more than 2%, absolute, a relative lift of anywhere from 8 to 24% across all those 3 hospitals. That's really cool. That ended up being $256,000 in reimbursement in just the first 6 weeks that we looked. If you make that proportional to the year, they're expecting around a $2.2 million return. And the average, if you're interested, the average increase in DRG payment was about $4,800 for each of those additional patients that we are helping them identify. Could show you, it wouldn't surprise you to know that if we showed you another health system where they were only capturing 3 or 4% of patients pre-go live, they had a really significant post-go live increase as well. But I think what's salient here and what the take home is this economic opportunity, this opportunity to improve outcomes for our patients, make sure we're capturing the clinical complexity of the population we serve, exists throughout the health system, even places where you think, oh, we've got this covered, we're doing a great job. Last slide to share with you today, and that is just how to get started. So it's really actually pretty easy. We can get folks live in as little as 10 weeks. Really just getting the data and training the models takes the bulk of that time. But we also spend time with you figuring out what your existing workflow is, to make sure that we're embedding this intelligence. As Katie was sharing earlier, like different places we can put this. It can be pre-populating an order for physicians. It can be adding an icon in the patient list. It could be in, if you wanted it, it could be an email or an in-basket message to your dietitians. Whatever makes sense from your workflow. Like we've spent a lot of time at Qventus understanding all the different places we can embed directly in Cerner and in Epic. So we're able to adapt to those existing workflows, which just eases the change management a lot. So within 10 weeks, you're up and running with this and driving outcomes. And as the last slide showed, those outcomes accrue very quickly. The last piece that probably people caught, and I didn't say, is it's also free for the first 2 months. So to make this as easy as a decision for folks as possible, we'll turn this on for 2 months. And for 2 months, you'll be able to see outcomes and see what we're driving with this. And if you decide after 2 months, you're like, I don't think I really want this, we'll turn it off, part ways. Been great to know you. But if it's driving outcomes for you, which we expect it will, as it has for all the other health systems, you can choose to leave it on, and we can talk about contracting terms. But the idea is no risk, easy to do. Start capturing the complexity of your patients, the reimbursement that's associated with that, and make it as risk-free as possible. That's what we had to share today. What other questions? I know we've been trying to answer stuff as much as possible throughout the conversation. What other questions do folks have? I see Jerry saying, what is this system? You have to give me a more specific question, Jerry. Like, what is it called? It's the Cuventus Care Gap Encoding.
I think it was on, Jason, the previous slide with the outcomes. And Jerry, on that one, we're still working with the marketing teams on, hey, are we able to publish those results yet and unveil that system? So those conversations are still happening.
Thanks for that clarification, Katie. I had a question I saw from earlier that was, what is the IT lift for getting this stood up? Do you want to take that one, Katie?
Yeah. As Jason said, it's pretty easy. We use Smart and Fire for a lot of the different polls that we're doing from a data perspective. And we have a data intake app that we actually install that helps us get that data more easily without setting up a bunch of custom feeds to get that data. So that's really the first step, is setting some of that up. That lift, it does vary a little bit, depend on the IT team that we're working with. But you can estimate anywhere from 30 to 60 hours of IT lift to get that in place. And that would include both the data ingestion and then the embed work as well.
And Katie, there was a question, I'll do my best to answer, but you may have more context. Elaine asked, have you seen any centers get flagged by CMS for increasing malnutrition coding? My impression on this is that not among our customers. We definitely have heard from health systems writ large that there's more scrutiny being applied by CMS. But I think, again, to that point of like, you really need an end-to-end orchestration to solve this problem, because we're able to make sure the provider knows why this patient qualifies, or even suggest documentation they can include in their note. Those are the gaps that CMS tends to flag people for. Either they don't meet criteria, and obviously we've got that done. We're applying Aspen and GLIM. They aren't getting active management, or the documentation doesn't meet muster. Like, you need to be covering up on all three of those to make sure you're not going to get an increase in that CMS scrutiny or refusals. Am I missing anything from that answer?
No, I think that's perfect, Jason. I think exactly like you said, what we're seeing is that because our solution ensures that dietitians are seeing all these patients and writing those notes, that's what I've seen most scrutinized. I actually had one client tell me 100% of the time that the dietitian did not see the patient, the code was overturned. 100% of the time that a denial was put in place, but the dietitian did see the patient, it was overturned, and it ended up being an approval. So I think that just goes to show that by helping move as far upstream in this process as possible to make sure that the care is also there is what's going to help secure that approval downstream.
And there's another question.
Amy.
Yeah.
So what we're doing is we're not only pulling the diagnosis into the physician's note, and to your point on whether it's discharge summary, like we can put it really wherever makes the most sense for the organization, but we do also pull the care plan as well, because I know that's a key part of both the approval process by the payer, but also I mentioned that malnutrition care score. Care plan is a key part as well to help ensure that you get 100% credit for all those patients that are diagnosed.
And I'd say the other piece we're working on, and Katie from the product side has more information on this than I do, but is making sure that care does get continued after the patient left the hospital. So if that is an in-network patient and going to one of your primary care clinics, how do we generate the either the outpatient consult order or the follow-up, or make sure it's part of that discharge summary that's going to that primary care doc that's going to see them, so that they know that that needs to continue, so you can continue to intervene on this patient, reduce ER visits, reduce readmission risk, improve outcomes for that patient.
Thank you, Dr. Cohn and Katie, for the discussion so far and for answering some of these questions coming in from the audience already. As a reminder to the audience, if you have any questions, you can submit them into the Q&A box on your screen. And our next audience question, can you share examples of structured and unstructured data that this is able to read and ingest?
Yeah, if we can go to slide 18, I think I can push that. Great.
Sorry, I went a little too fast. I think we're both hitting the advance button. There, 18. I'm going to stop and just let you take it.
I will stop.
Okay, I'm going back.
We did it. Perfect. We did it. So yeah, these are those examples. So from the structured side, we're looking at, of course, weights. We do look at past encounter weights as well, right? So I know with malnutrition, you're looking at that weight loss over the last 6 months, the last 12 months. So we do incorporate that too. We'll look at BMI. This is particularly useful for GLIM in particular from a diagnosis perspective, but I know a lot of other clients, even that are on Aspen, use that. Standard vitals, we'll be monitoring some of those labs and whatnot that can help, not necessarily diagnose, but give additional context to what's going on with the patient. And then on the unstructured side, we're looking at energy intake reduction. So this, we typically look at some of the nursing documentation on how much patients have been eating. We're also looking for things like, is the patient have a lot of nausea, vomiting, that would indicate some of that. Fluid accumulation. One thing probably worth calling out here is that for heart failure patients, we actually treat this a little bit differently, knowing that those patients will naturally retain a lot of fluid that isn't necessarily indicative of being malnourished. Same with the weight loss for those heart failure patients. I mentioned the fat loss, the muscle mass loss. We, of course, the physical exam will find that, but we have found that there's some documentation on that in physician notes that we can pick up. And you can see some of the others on this screen. So a lot of different indicators that we're picking up and surfacing to folks so they have very clear visibility on what we picked up and why.
Thank you. And our next audience question is, what is the experience like for a provider using this solution? How does it fit within their workflows?
Yeah, I'll tackle that and say that, again, really, I'm harping on the same thing, but really important that you integrate this in a way that actually reduces people's workload and makes sense. So we're not going to just be throwing alerts at providers, but if I'm in this patient's chart and I've already, I'm either closing order entry or I'm closing the chart and moving to another patient. If I haven't taken this step, like that's the point where we'll actually pre-populate the order for that provider. We'll say, hey, looks like this patient has severe protein calorie malnutrition for these reasons. All you have to do is order this consult here, and then later we can even offer that that documentation. So again, like the current, I would say, experience for providers is either maybe you have a dietitian at your multidisciplinary rounds and they ask you for a consult while you're there, or maybe you get pinged by CDI after a patient's already been discharged and you're asked to go amend a discharge summary. All that stuff is highly manual, relies on motivated individuals doing the right thing. This is automating those steps, making sure it happens at the right time so you can intervene on the patient. And again, at the right moment in your workflow so that it's seamless and it's easy to do the right thing. I hear you frantically typing, Katie. Are you answering a question?
I was answering a question. Picking up my keyboard.
Do you want to share it with anyone else?
Yeah. So Heather, you were asking about, is the care plan you mentioned a nursing or an RD care plan? So our models look at both care plans, but the ones that we're automating into the physician progress notes is the dietitian care plan, as that's what's most relevant to that malnutrition diagnosis. Stop frantic typing.
And Jay, I think you're asking about you might want to take this one too, Katie. I don't know if you can see it. Jay is asking, is the finance model a SaaS model, or is this a percentage of missed reimbursement?
So it's a SaaS model. So we price based on discharges. So I know on the missed reimbursement side, want to make it as compliant as possible. So we don't want to raise any alarm bells that we are in any way incentivizing or driving any financial agreements based on patients that we do end up getting coded as malnourished. These models, of course, also run on a per patient basis. And I think to the other point, we've talked about this being a suite. It's not just malnutrition. So as more conditions get added, the per discharge pricing model, it's not that it's doubling every time, like it's increasing by like 50 cents, $1 as we're adding more conditions, because this model, we're getting some of those efficiencies of scale and passing that back on to our partner organizations. So in short, probably more color than you wanted, Jay, but it's a per discharge pricing model. Anything you add there, Jason?
No, no, yes. Jay, like, obviously, if you want to talk about this with us, like, give us a yell. We can talk about how many annual discharges you have and like how many hospitals, and whether you want to start with a pilot or just spread out across the whole system. All of that, has an impact there. But SaaS model. Yeah. And I think that's the last question. So thanks so much to everyone for your time today. Again, the only thing I'll add here is this is pretty exciting to me. I think we're finally, we all hear about AI in our daily lives all the time. Like, for me as a physician, like, AI is cool and all, but I want it to actually help me get the right care for my patients. I want it to reduce the burden in my daily life. If possible, I want to decrease the cost of care that we're providing to patients, and make sure that our health systems are able to meet our mission to our communities. And I think I'm excited about this because it enables us really to hit all those core components of the triple aim or the quadruple aim, or quintuple aim from the IHI that we all care about and are really devoted to. Katie, any final words from you? Sorry to put you on the spot.
That's okay. No, I was on mute for my typing. So getting off mute. No, I'll just say no, but yes, right? This has been really great to get to talk to you guys about this, because clearly you guys have thought about this problem based on what we're chatting about in the chat. So I'd love to continue the conversation and talk about how this solution can help at each of your organizations. So I'd love to keep chatting.
Have a great week, all. Take care.
Thank you.
And thank you, Dr. Cohen Kay, for a great conversation. And thank you to Ventus for sponsoring today's webinar. And thank you to the audience for joining us. And we hope you all have a wonderful rest of your day.